Good afternoon, everyone. Thank you for joining today's webinar entitled Traumatic Brain Injury in the Criminal Justice Population. This webinar has been sponsored by the Bureau of Justice Assistance and the Council of State Governments Justice Center. My name is Nicole Jarrett, Senior Policy Analyst at the Council of State Governments Justice Center, and I will be your monitor for today's discussion. Before turning the webinar over to the featured speakers, I'd like to briefly talk through a couple of housekeeping items about how the webinar is going to work. Anytime during this webinar, you can ask a question by typing it into the Q&A panel at the bottom right-hand portion of your screen. We'll keep a running list of the content-related questions that we receive, and then ask the panelists to respond to the questions during the last segment of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues we may not be able to resolve. For this reason, we are recording this event and will post it on our website within a few days. And once it has been posted, you'll receive an email that will include a link to the recording. Today, our presenters are Ashley Bridwell and Dr. Ross McDonald. Ashley Bridwell is a Rehabilitation Program Coordinator and Clinical Social Worker at St. Joseph's Hospital and Medical Center in Outpatient Rehabilitation and the Brains Clinic, where she specializes in neurological disabilities. She is also adjunct faculty at Arizona State University Center for Applied Behavioral Health Policy, where her research efforts focus on traumatic brain injury in vulnerable populations. She has led numerous workshops and trainings for health and human service providers, law enforcement, and community supervision personnel. Dr. Ross McDonald is the Medical Director of the Bureau of Correctional Health Services for the New York City Department of Health and Mental Hygiene. Dr. McDonald's role as Medical Director involves oversight of care provided in the New York City jail system, formulation and application of department policy in a wide range of medical conditions, clinical decision support, training for clinical staff, ongoing review of adverse events, and patient complaints, as well as direct patient care. Dr. McDonald's current projects include investigating traumatic brain injury prevalence and incidence in incarcerated populations. We are very excited to have this terrific group of presenters here today. Today's presentation will be divided into 4 parts. First, Ashley will begin our presentation describing what TBI is, including how we distinguish the condition in terms of severity. Next, we'll focus on the cognitive, emotional, and behavioral effects of TBI. Dr. McDonald will then lead the discussion on TBI among people who are involved in the criminal justice system. And the presentation will conclude with a discussion on key considerations and approaches to improve our responses to this population. I will now turn the presentation over to our first speaker, Ashley Bridwell. Good afternoon, Ashley.
Usually start out the training call with a weather report. I am in Phoenix, and it is a beautiful 75 degrees here. When Ross and Dr. McDonald and I first got on the phone together, I asked him how the weather was, and he'd rather not talk about it. So I'm sure that they will be glad to no longer get the Phoenix weather reports. So with that, we'll start with just talking a little bit about the prevalence of traumatic brain injury. I think we've been hearing about traumatic brain injury more and more in the news more recently over the past couple of years. A couple of years ago, we saw the tragedy of Congresswoman Gabby Giffords, who sustained a gunshot to the head. We also hear a lot about the signature wound of this war, OEF, OIF, OND. Men and women coming back from theater have very high prevalence of mild traumatic brain injury and post-traumatic stress disorder, which we're going to talk about in some future slides. We did just see in the State of the Union address that First Class Corey Rimsberg was given a very long-standing ovation for his service to his country and has sustained a traumatic brain injury, I think, in his 10th deployment. Maybe in his 9th deployment, he was getting ready to go on his 10th. So I know that from working with physical therapists that when Corey went to stand up to receive that standing ovation, he had a whole team of physical therapists that were really sweating it that he made it up and got okay. So it was great to see that. Also, we've heard in the news about the National Football League or the NFL agreeing to pay $765 million to settle thousands of player lawsuits over head injuries. So the case actually stems from some 4,500 players coming forward with long-term symptomology from traumatic brain injury. And with that settlement, they also are giving money post-mortem to players that post-morbidly had findings of chronic traumatic encephalopathy, which is the condition that happens as a result of long-term sustained mild traumatic brain injury. And we saw Dave Dewerson and Junior Suau commit suicide. And I think it was Dave Dewerson who had left a note that said, please make sure that my brain goes to the NFL Brain Bank for studies. And so through that, they've been able to learn more and more about chronic traumatic encephalopathy. So those families will not be excluded. And then lastly, just in terms of prevalence and sort of overall increased awareness for traumatic brain injury, as of January 30th, 2014, all 50 states, including Washington, D.C., have passed laws protecting student athletes from returning to play too soon after suffering the effects of concussion. So, and a lot of that stems from some of the very rare cases that we've seen across the country of second impact syndrome, which is when an individual sustains a concussion and then returns to play prior to the concussion symptomology resolving. If they sustain a second concussion prior to the first concussion symptomology resolving, it can result in sudden death or very severe lifelong disability. And although these are rare cases, they have occurred in a couple of teenagers across the nation that really kind of started the parental push for making sure that there was a standardized return to play post-concussion protocol. So that's just a few instances of how we're just seeing traumatic brain injury more and more pop up in the news and kind of our everyday life, and especially if you have kids that are currently playing school sports. So moving on to the next slide, which should be happening right now. Okay, so in this slide we kind of look at, so this is the Center for Disease Control definition of traumatic brain injury. We also look at sort of from a nationwide perspective, 2002 to 2006, just looking at rates of death, hospitalizations, emergency department visits. And I think what's important to talk about this specific graph is that bottom rung, receiving other medical care or no care, I think there's probably quite a few people that will go to their private practice primary care physicians or physicians that sort of don't get calculated into this equation. I think there's probably also a fairly large majority of individuals who sustain injuries to the brain that are uninsured and don't have access to medical care, and so they kind of go uncounted. So I would say that bottom rung is a fairly large rung. But in terms of looking at some Arizona numbers, just for our Arizona folks, so we have about 6 million people living in Arizona. And in 2011, we saw about 1,400 deaths secondary to traumatic brain injury. The highest rates of those deaths were among Indigenous or Native American and non-Hispanic Caucasian. And the leading causes of death were secondary to firearms, homicide, and suicide. And then the second leading cause was falls, and thirdly, motor vehicle accidents. We saw about 7,000 hospitalizations. We saw about 50,000 non-fatal emergency department visits from 2005 to 2010. We saw about $451.8 million in hospital costs, and we also saw about 33,000 days in the hospital. And that's just looking at Arizona, so it kind of provides you some context in terms of, what you might expect in your own state. So, traumatic brain injury is, an interesting way, is the leading cause of death and disability in children. If you're a brain injury geek like myself, I guess those things are interesting. I'm not sure they're interesting to everybody, but 400,000 brain injuries in children under 15 every year, and more than half of the TBIs occur before the age of 25, because we're still not always making great decisions until that frontal lobe gets fully developed at 25. So this actually makes brain injuries 8 times more likely than breast cancer, which is usually one of the statistics that kind of blows people away. And I always joke that, if brain injury awareness had something as cool as those rubber bracelets that say "I love boobies" on them, that we would probably have a much easier time increasing brain injury awareness. But we haven't quite figured that out yet in the brain injury community. So it actually makes it 34 times more likely than HIV/AIDS as well. So the leading cause of traumatic brain injury, just in the general population, is the leading cause of traumatic brain injury is actually falls. Second, assault, falls make up about 35% of all injuries. And then we see sort of the unknown, which is about 21%. We see struck by or against in about 16.5%, motor vehicle accidents in about 17%, and assault in about 10%. So based on falls being the most popular way to sustain a brain injury, the age ranges that make the most sense associated with that indicator is the 0 to 4 range and the 65 plus range. So those are actually our 2 age ranges that are most at risk for sustaining traumatic brain injury. So next, we're going to kind of do the brain injury 101. I don't think any of us are going to walk out of this webinar neurologists, but we'll give it kind of a good shot in terms of looking at how to describe this. So, when we think about brain injury, we think about it in 2 sort of major subsections. We think about it in terms of congenital brain injury, and we think about it in terms of acquired brain injury. So, congenital brain injury, this actually occurs prior to birth. So, we use the terminology CP or cerebral palsy, which is sort of a large umbrella that can encompass quite a few sort of neurological things that can go on in utero. So intraventricular hemorrhages, intracranial hemorrhages, encephalitis, neonatal infections, things that happen either prior to birth that affect the structural physiology of the brain. And then shifting over to the acquired brain injury, which is kind of the focus of our discussion today, we look at that sort of in 2 categories. We look at it in terms of traumatic brain injury and non-traumatic brain injury. When we talk about acquired brain injury, we talk about it in the context of something that is not hereditary, is not congenital, it's not degenerative, and it wasn't induced by a birth trauma. So it was something that occurred outside of all of those things. So when we look at acquired brain injury, we look at it in the context of traumatic and non-traumatic. And in the 10 years I've been working with the neurological population, I would probably tell you that every stroke patient that I've met has told me that they had a traumatic brain injury. It was pretty traumatic to them. So, not to say that the terminology actually represents the condition, but traumatic brain injury is caused by an external force after birth. And then a non-traumatic brain injury is something that is caused organically. So looking at aneurysm, AVM rupture, encephalopathy, anoxia, which can be something that occurs as a result of a drug overdose, or myocardial infarction, the time of the brain that when it's deprived from oxygen creates that anoxia. So those are kind of more the non-traumatic ends of things. Damage done as a result of brain tumor resection, et cetera. So, and then under the traumatic brain injury heading, we look at closed and open injury, and this is sort of self-explanatory in the sense that, a closed injury is a closed injury. The brain hits the inside of the skull, versus an open head injury where you're looking at something penetrating or where the brain is exposed. So that kind of gives you a context in terms of how we sort of separate out traumatic versus non-traumatic and closed versus open. So next, we're going to talk about severity of traumatic brain injury. And so this is something, when you're assessing, you have, an individual in front of you and you're trying to get an idea of if they've sustained a traumatic brain injury, and then you're trying to figure out sort of how bad it was or how much you can anticipate that individual is going to have difficulties as a result of their brain injury. There's a couple of sort of quick and dirty ways I think that you can sort of get a sense or an idea. The first one is, I'm going to just pay special attention to the Glasgow-Coma scale for a second here. So if you can get a hold of medical records, if you're working with somebody with a traumatic brain injury and you want to kind of get a sense of how bad or how severe of an injury that they actually had, if you can get a hold of the medical records, one of the things that is going to be in the majority of the reports, and especially the trauma report, is going to be their Glasgow-Coma scale score. And that's going to give you a pretty good idea or indicator of what the severity of their injury is. So the Glasgow-Coma scale is on a scale from 3 to 15, 3 being essentially non-responsive, and usually that doesn't end up very good for the individual, to 15 being totally responsive and responsive to command, and et cetera. So the way they determine what the Glasgow-Coma scale is a few different areas that they test during that initial trauma. So eye-opening, motor response, and verbal response. So just giving a quick example about the eye-opening piece. So eye-opening is on a scale of 4. So, and it ranges from purposeful to responsive to simple stimuli to non-responsive. So, for example, if somebody has a 1 on the eye response scale, it means that there's no eye opening. If they have a 2, it's an eye opening to pain. If they have a 3, it's eye opening to verbal command. And if it's a 4, their eyes are open spontaneously. So then the verbal response scale is actually a scale of 5. The motor response scale is a scale of 6. So if you can get your hands on some medical records and you happen to notice what the Glasgow-Coma scale score is, and you look down and it was a 4, you kind of have a fairly good idea that that was a pretty severe injury, and the likelihood of somebody having long-term, lifelong changes as a result of that are pretty good. Now, I've been working in brain injury rehabilitation for 10 years, and I was talking with a colleague this morning, and we were chatting about how we've both been fooled by those Glasgow-Coma scales, where we do a chart review before the patient comes in, and we're expecting somebody to come in, very affected by their brain injury, and they sort of come in walking and talking and, kind of unexpectedly way better than thought they were going to be. So although it's a pretty good indicator, it's not always foolproof, and unfortunately most things are like that in brain injury medicine, just because the brain is such an incredibly complex organ, and it's so different, and we're all so unique. So the other way to sort of quickly assess or try and quickly assess the severity of the injury when you're talking with somebody about their injury is the length of stay in the hospital. So I think we've all had the experience where we were pretty sure we maybe should have been admitted to the hospital, but they sent us home. Same with traumatic brain injury. If you have an injury, you come to the emergency department, you have a clean CT scan and some symptomology, they're more than likely going to send you home. But if the individual that you're working with is saying that they spent, a few nights in a hospital or a significant amount of time in a hospital, if you can corroborate that, and that's actually a true story, maybe get some medical records. Again, that's another way to sort of determine the level of severity of that individual's injury associated with the amount of time that they spent in the hospital. Because if there's a way to get somebody out of the hospital these days, that's certainly, discharge is certainly what to expect. So just quickly in terms of looking at mild injury, so altered or loss of consciousness, I think everybody at this point knows that you don't have to be unconscious to sustain a concussion. The athletes call it, getting your bell rung or seeing stars. So that would be kind of what we talk about as a mild injury. Your loss of consciousness is less than 30 minutes. You have a totally normal CT scan. Your Glasgow-Coma scale is anywhere between a 13 and a 15. with post-traumatic amnesia less than 24 hours. So just very quickly about post-traumatic amnesia, because I don't want to spend a lot of time on this. Post-traumatic amnesia is a recovery process of the brain. It essentially is an amount of time after a moderate to severe injury where you can't lay down new memories. You're agitated, you don't kind of know where you are, you're not oriented, and the longer that post-traumatic amnesia lasts, sort of the more indicative that it is that that individual is not going to rehabilitate at a fairly high level. But in the more mild injuries, we don't see a lot of post-traumatic amnesia. Typically, people can't remember the acts if they were in a car accident, sustained a concussion. Oftentimes, they won't be able to remember it. But moderate loss of consciousness, less than 6 hours with abnormal CT scan, a Glasgow Coma scale between 9 and 12, and post-traumatic amnesia, less than 7 days. And then we look at severe injury, like Gabby Giffords, a loss of consciousness is greater than 6 hours with abnormal CT scan. Glasgow Coma scale less than 9, and post-traumatic amnesia greater than 7 days. So this kind of gets back to that, the majority of traumatic brain injuries that we see are the mild type. The majority of pediatric traumatic brain injuries are mild, especially in children ages 5 to 14. Typically, these are sports related. When you have a mild traumatic brain injury, the majority of individuals will recover, and I think we're going to talk about that in the next slide here. But there is a percentage of people in this 85% that aren't accessing care. So traumatic brain injury severity and recovery. So when we talk about mild traumatic brain injury, certainly there is some studies and some literature and some information about the cumulative effect of mild traumatic brain injury, and with every injury you sustain, the harder it is to recover from those deficits. And oftentimes, after sustaining multiple, there are deficits that actually do not improve, or they're sort of long-term. But most people with mild traumatic brain injury may have complete recovery within 3 to 7 days, or symptoms resolve. I think we can probably all think back to a situation where we had, a concussion, we saw scars and the little tiki birds that kind of around our head. And we got better and life went on. But there is a sort of miserable minority that have a chronic disability as a result of mild traumatic brain injury. And the literature would suggest that those individuals have prolonged symptomology of mild traumatic brain injury based on premorbid complex migraine or history of psychiatric issues. So we developed a mild traumatic brain injury clinic here at St. Joe's in the Barrow that was specifically designed to kind of get people into rehabilitation, do some quick injury screenings and assessments, give them some strategies, and get them out the door, because the majority of them do get better. But we do see a percentage of individuals that have sort of these prolonged, ongoing symptoms of mild traumatic brain injury, and it would seem that the psychiatric symptomology, there's a fairly high correlation there. So I just want to talk quickly about what an ideal brain injury rehabilitation program looks like. I have been fortunate enough to work at St. Joseph's Hospital Medical Center and Barrow Neurological Institute for the past 10 years, and have been a part of an interdisciplinary team that has addressed neurological recovery. So traumatic brain injury, stroke, the traumatic injuries, the non-traumatic brain injuries, closed, the open, work kind of like Ellis Island. We take them all, and we treat them really good. So when we look at ideal brain injury rehabilitation, these are some of the specialists that we would hope to see involved in a traumatic brain injury rehabilitation program. So physical therapy, everything from the waist and down, including seating and mobility, endurance building, balance. Physical therapy also in the mild traumatic brain injury population spends quite a bit of time treating the vestibular system, which is our inner ear, and there's a lot of dizziness in the mild traumatic brain injury population. And so there are therapists that specialize in working with this population and have some specialized techniques and so on and so forth that they can use to help to resolve some of the dizziness. Occupational therapy is everything from the waist and up, including activities of daily living, as well as visual perception skills, helping get people back to driving. Speech therapy services here at the St. Joe's in the Barrow, our speech therapists that work in our neurological programs focus on cognitive retraining. So it's memory, attention, concentration, They do focus on language and swallowing as well. But with the brain injury patients, I would say the large majority of them are being treated for the cognitive aspect of their brain injury. So then neuropsychology, neuropsychiatry, social work, my favorite, recreational therapy, physiatry, a physical medicine and rehabilitation specialist is involved, and we also have some fantastic neurologists. So our average length of stay here for a brand new brain injury is anywhere between 4 and 6 months. So, and even some of our mild injuries will stay that long, depending on how they're doing and if they're making progress and if we're working towards those goals. So, think about this in context of the people that sustain injuries. This is the ideal scenario for about 4 to 6 month time frame to really get back to hopefully where they were, but as close to where they were as possible, and then developing compensatory strategies for the deficits that are not going to improve. So I'll talk quickly about the physical effects of traumatic brain injury. So in terms of, you can see kind of a list here. I would say in context of sort of this discussion of correctional health, the slowed verbal and physical responses could be interpreted by a correction officer as uncooperative behavior. We actually saw an inmate a few months ago in the Brain Clinic, which stands for the Barrow Resource for Acquired Injury to the Nervous System, which is one of the first medical multidisciplinary programs to address brain injury in the nation. It is very cool over there. We had an individual come in, I believe from our Florence jail, that during his arrest had been tackled by a canine officer. There was some drugs and some guns involved, is what I understand. So he did sustain a small subdural hematoma, which is bleeding inside of the brain. It didn't require evacuation, but as a result of the subdural hematoma, he did have really, really significant dizziness that made his gait appear that he was intoxicated. He was sort of all over the hallway and was not able to walk in a straight line, and was very difficult to keep in the cuffs at his ankles. And so the physician examined him and was able to do a maneuver on him called the Dix-Hallpike maneuver, which was actually they were able to put his crystals sort of back to where they belonged in his inner ear, and it resolved the dizziness right away. And it made him feel so much better, and it made it a lot easier, obviously, for him to be transported and that sort of thing. So it's just as a quick example of a physical effect of traumatic brain injury. And now we're looking at cognitive effects of traumatic brain injury. And so I think this is going to be the biggie in terms of the environment, the correctional health environment. So, for example, attention deficits may make it difficult for the inmates with traumatic brain injury to focus on a required task or respond to directions given by a corrections officer. Either situation could be misinterpreted, maybe leading to the impression of deliberate defiance on the part of the inmate. Memory deficits can make it difficult to understand or remember rules or directions, which also may get somebody into a little bit of trouble. And, when I go to the homeless shelters, I talk about that a lot in terms of, they have a lot of rules as well in terms of curfew and where you can put your stuff and what the visitor policy is and those sorts of things. And so try and build some empathy in that area. So I did a training in Tucson recently, and a correctional health officer was there. She had been in the business 20 years and said that one of the ways that she had sort of found best to sort of assess an inmate's cognition is, she had somebody that was really, giving her a hard time in terms of, I don't remember, or I wasn't paying attention, or whatever. She would watch them in all areas and sort of assess their cognition in different areas within the jail or the prison. And so she was telling a story about this one individual in particular that really was having a difficult time sort of learning the rules and paying attention, and then he would go out to the yard and sit with his buddies and learn a brand new card game and play it all afternoon. So, she was able to sort of assess that maybe there was some exacerbation of symptomology and that sort of thing in that specific individual. So I thought that was an interesting thought. And then in terms of behavioral effects of traumatic brain injury. So irritability, agitation, so they may have difficulty controlling their anger, which can lead to an incident, obviously with correctional health officer or other inmates. Such incidents can lead to further injury. And this is, one of those statistics in brain injury that once you've sustained a brain injury, you're twice as likely to sustain a second injury as a result of probably poor impulse control, poor decision making, and that sort of thing. So those are, and when we think about brain injury, we think about it in context of physical, cognitive, and emotional deficits as a result of the injury. So we could spend sort of all day talking about what those look like. But I've highlighted just a few here. So I'm going to turn the slide and turn it over to my buddy, Dr. McDonald.
Thanks, Ashley.
Sure.
It's important to point out that the prevalence of TBI in prisoners is much higher than it is in the general population. I think those of us who work in correctional health or with incarcerated populations are used to hearing that the prevalence of this condition or another is higher in our population. But I think it's particularly important with regard to TBI because there may be some causal relationship there. The data is difficult to tease out and hasn't been established yet, but for many of the reasons that Ashley described, some of the downstream consequences of traumatic brain injury could predispose to future offending behavior. And this very strong correlation has been described in the literature. A study in 2013 looked at this by defining three groups who had sustained injuries as children. And these injuries occurred at least 5 years ago so that the intervening behavior and criminal justice involvement could be measured. So the three groups were two TBI groups, one with moderate to severe TBI, one with mild TBI, and a control group with orthopedic fracture. So these are children who injured themselves badly but not with a brain injury. And what they found was that the moderate and severe TBI group was more likely to have a history of offending behavior, arrest, conviction, and petty crime. By the time they measured these things, at least 5 years from the time of the injury. Similarly, in studies in prison, it's known that incident TBI, so traumatic brain injury that is sustained in the prison setting, leads to higher rates of future infraction. So this was a study published in 2010 that looked at medically attended TBI. So these are prison inmates who ended up in the hospital with a TBI-related ICD-9 code. They found that those who had sustained TBI were older, more likely to be black, had a higher proportion of violent offense convictions, longer sentences, and had served more time. And they found a prevalence of TBI overall of about 1.2% for men and just under 1% for women. After controlling for various variables, including age, violent crime convictions, prior criminal history, security level, and sentence length, they found that the cohort that had sustained a TBI while in prison had higher rates of infractions per year subsequent to the TBI. This was true in the males, and there was a trend in females, though it wasn't statistically significant. So it's important to point out that neither of these studies really established causality. To say that brain injury leads to changes in behavior that lead to problems with the criminal justice system or problems in jail. But that relationship makes a great deal of theoretical sense for so many of the reasons that Ashley described. So we know that the downstream effects of TBI are behavioral changes, many of which might predispose to the types of things that could get you arrested or that could get you infracted. So we haven't established causality, but there's good reason to believe that this relationship could exist. And what we do know for sure is that this problem is incredibly prevalent in the patients that we treat in incarcerated settings. Ashley?
Okay. All right. So, in terms of sort of looking where we're at today, we look at sort of gender-wise, among male prisoners, history of brain injury strongly associated with perpetration of violence and other kinds of violence, and then for women, and the project that I've been doing with ASU has actually been more focused on justice involved women specifically. Women inmates who are convicted of violent crime are more likely to sustain a pre-crime traumatic brain injury and or some other form of abuse. And we know that there is a very high rate of women that are incarcerated that have experienced domestic violence. So, you know, in terms of sort of the question of, well, why? Well, you know, I think when we talk about traumatic brain injury, you know, our brain is sort of floating around in this fluid inside of our skull. And so, by design, our skull has these sort of bony ridges right behind our forehead. And so when we're in an accident, and we're rear-ended, you know, we kind of think about our brain or our head going in the forward motion, and then we think about it going in the backward motion. And this is actually my favorite brain injury term. It's called coup contra coup. And when I do live presentations, I usually make everybody say it with me just because I think it's kind of a fun word. But that's that sort of brain injury beat coming out of me again. So we have those bony ridges in front of our forehead that make the frontal lobe really vulnerable to injury. So, you know, if we sustained a car accident resulting in a vehicle accident, or even, you know, if we think about assault, being hit by behind or falling down a flight of stairs, those sorts of things, you know, we think about it in context of our frontal lobe, and our frontal lobe is sort of our manager. And so we look at frontal lobe dysfunction causes poor impulse control, it increases agitation, emotional ability, difficulty thinking things through. So, you know, in the context of the frontal lobe, you know, I would say that there's a fairly, you know, it's an easy sort of jump to make that if we have frontal lobe dysfunction and maybe we haven't had the appropriate type of brain injury rehabilitation and we don't have the right family support and we don't have somebody sort of monitoring our behavior, I think there's probably an increased chance that we could be making some bad decisions that leads to incarceration. So in the next slide here, we're going to talk about intimate partner violence. And this is sort of the statistic I was referencing. You know, 75% of imprisoned women experience physical, psychological, and sexual violence in prison. We at the Barrow in St. Joe's were actually fortunate enough to obtain some grant funding through a couple of organizations local here, the Hawley Foundation, as well as the Board of Visitors just recently, to do brain injury screening in a total of 3 domestic violence shelters. So we are using the health screen, which I think Ross is going to talk a little later in the presentation about different types of screening tools. The health screen is a real quick and dirty assessment. It's have you hit your head, have you been to the emergency room, have you lost consciousness as a result of hitting your head, and have you had problems since you hit your head. Every man and woman that checks into the domestic violence, these 3 specific domestic violence shelters, we're partnering with UMOM, Chrysalis, and we have a single ladies shelter that we're also partnering with. So they get screened at intake for traumatic brain injury, and if they screen positive, they come here to the brain clinic, the Barrow Resource for Acquired Injury to the Nervous System, and they are evaluated by myself and a neurologist, one of the top neurologists in the country, actually, evaluates them, and there is access to MRI imaging and neuropsychology and neuropsychiatry and therapies and the whole deal. So we've been running this program for about a year and a half, and we've seen about 200 women, and although I don't have the hard data yet, and we're still working through the IRB process, if anybody's been through that process, I'm sure you can empathize with me. But it's looking to be about 7 to 10% of these women have worse than a mild injury to their brain, which means there was actually structural changes in their brain as a result of bleeding. So there's certainly, and a large majority of these women also have been justice involved, are on probation or on parole and have these significant impairments in their cognition and some physical symptomology and that sort of thing. So it's just been a very interesting couple of years. We did actually just get refunded, and so we're going to be able to expand to 3 additional shelters in this year. We're also going to start doing some cognitive training groups in the domestic violence setting so that they can sort of have access to some therapists in their own environment as well. So we're starting to kind of see that correlation between brain injury and domestic violence, and then certainly between brain injury, domestic violence, and incarceration. So my passion for this subject actually started as a result of being part of the 100,000 Homes campaign. And I don't know if any of you were tuned into 60 Minutes this past Sunday with Anderson Cooper, but he did a special on the 100,000 Homes campaign, which is a national campaign to end chronic homelessness. So I was out in the middle of the night with some colleagues surveying chronically homeless individuals, and I don't know if it was the universe or what, but everybody that I talked to responded positively to the question, how do you sustain a traumatic brain injury? And so the idea is to figure out who the most vulnerable homeless individuals are in your community and house them in a housing first type model. So we were assessing their medical conditions based on the vulnerability index, which was developed by Dr. James O'Connell through Boston Healthcare for the Homeless. And what we discovered was that 25% of everybody that we surveyed throughout those 3 days, and roughly 360 surveys, were 25% of them had responded yes to that question. When we went to Tucson, we did the same vulnerability index, same routine, got up at 4 o'clock in the morning to sort of capture the sickest homeless individuals that weren't accessing, they were too sick to even access shelter. Same statistics, about 20 to 25% has indicated positive to that question. So that's sort of what started my interest and my passion to really look at the correlation between homelessness and brain injury, and that sort of led into domestic violence and the incarcerated, and then sort of a natural transition there. But so just quickly, in terms of looking at some of the data that's come out about homelessness, specifically in traumatic brain injury, in Wisconsin, they studied about 90 homeless individuals. 80% were found to have cognitive impairment, brain injury related. A second study in Boston looked at about 152 persons in homeless shelter reported having head injury. 71% reported having more than one injury. 73% reported being hospitalized after the injury. So we now know that they were homeless and hospitalized. That injury had been pretty significant. 77% of the 73% hospitalized had no follow-up or treatment. So, when we think about the correlation between brain injury and homelessness, I would say that, again, getting back to the why. I think street-related violence is probably an easy assumption. The other statistics that really stick out in the homeless population is that a large majority of individuals that are homeless lived outside of their family of origin, so they were in an institutional setting or they were in a foster care setting, and so, again, sort of thinking about an assumption that there was a reason they were removed from their family of origin, usually abuse, and people's experiences with foster care and institutional settings certainly vary, but there's, question mark there in terms of, did they sustain, injuries during that period of time. And then we look at the way homeless individuals transport themselves. They ride bicycles, and I pretty much have never seen a homeless individual with a helmet and a bicycle. So there's that, as well as just being a pedestrian, and if you're really, especially in Phoenix, it seems like really at risk for being hit by a car. And then, the idea that somebody sustained a traumatic brain injury and weren't treated didn't have the proper follow-up, and sort of the domino effect started to occur. They weren't able to maintain their employment. Their family got burned out. Maybe they started self-medicating with drugs and alcohol. We have a gentleman here in Phoenix that we've been working with. His name is Mr. 210, because he's had 210 emergency department visits in the past 365 days. He did sustain a traumatic brain injury and then became homeless and has really bad seizure disorder and is just having a very difficult time. St. Joe's started a program called Frequent Users of the St. Joe's ER, where we were able to sort of look at the 15 top users and offer them permanent supportive housing, with the cost savings being obviously enormous for the hospital, but also for the community at large, because Mr. Tuta is no longer using EMS, jails, inpatient psychiatric hospitalization. So it's an interesting population to work with. So next, just quickly talking about the military in terms of traumatic injury. So,
Ashley, this is Sean. I'm sorry to interrupt you. Can you make sure that the microphone, that you're holding the microphone steady? We're getting several comments that the audio is.
Sorry, is this better?
That's better. Thank you.
Okay. Sorry. Yeah. Sure. Okay. So with this graph, we're seeing that the large majority of service members returning are returning with mild traumatic brain injury. We see moderate and severe here as well, and then we've got some that are sort of not classifiable. So, I always think about that Robin Thicke song, Blurred Lines, when I think about post-traumatic stress disorder or mild traumatic brain injury, because 80% of the symptomology is the same or looks the same. So it's very difficult to tease out what is the ramification of mild traumatic brain injury versus post-traumatic stress. So one of the things that the military is doing, which is really exciting, is that they actually have a new policy about traumatic brain injury. So prior to this, the service member would have to volunteer the information that they had sustained an injury and that they were having symptoms, which, for those of us that know veterans and active duty folks, the likelihood of that happening is pretty slim. So what they've done now is they're making this policy that they're calling it event-driven. So it's about somebody else seeing an actual event take place, and then instead of the service member having to self-report, just because the event occurred, that brings mandatory downtime and mild traumatic brain injury assessment. So that's a very good step in the right direction. They're doing a lot of studies right now about traumatic brain injury and post-traumatic stress disorder. Some of them are saying that if you control the post-traumatic stress disorder symptomology, that there are no long-term symptoms from depression. It's very difficult for me to believe that there's an actual way to control all of the symptomology of post-traumatic stress disorder to make that statement. The other thing that they're not taking into effect, but I think is really important, is the cumulative effect of mild traumatic brain injury. So, the difference between the guy that's had one mild traumatic brain injury versus the guy that's had 50. So, and there's obviously going to be a significant difference in terms of long-term ramifications. So just a quick slide here. So we talk about veterans and traumatic brain injury. We talk about it in context of correctional health. 10% of people incarcerated are veterans. Combat experiences left a growing number of veterans with post-traumatic stress disorder and traumatic brain injury. We kind of just talked about that. And then, and maybe Ross, you'll want to say something about this. In 2008, Judge Robert Russell founded the Veterans Treatment Court in Buffalo, New York. And I know there's sort of these veteran-specific courts, and we're having our annual veteran stand-down this coming weekend, which I believe we're either the second largest in the nation or the first largest in the nation, or second or first to San Diego. But we do have a specific veteran court within the stand-down where they can come and get some of their homeless-related charges down to community service hours, which they're able to complete during the 3-day stand-down event. So it's a fantastic idea. So I'm going to advance the slide and then give it over to you, Dr. McDonald.
Thanks, Ashley. So in addition to being highly prevalent in incarcerated populations, traumatic brain injury is also highly comorbid with a few other conditions that are prevalent in our population, in particular substance abuse. This is another situation where the causality is difficult to tease out, and likely it's a bidirectional causality. In other words, substance abuse disorders predispose to traumatic brain injury. We see this certainly with regard to alcohol abuse. And traumatic brain injury tends to worsen substance abuse disorders. So many of the downstream sequelae can be similar to psychiatric conditions such as depression that our patients would self-medicate with drugs of abuse. Similarly, mental health. So we know that mental illness has a higher prevalence of traumatic brain injury, and we're not sure exactly in which direction that goes, or more likely if it goes in both directions. So that certain mental illness may predispose you to sustaining a traumatic brain injury, and many of the downstream effects of traumatic brain injury may worsen underlying mental illness, or in some cases be misdiagnosed as mental illness. And Ashley mentioned PTSD, where there's a significant amount of overlap. Ashley went over some of this, but I think it's important to revisit just because for those of us who work in jails and prisons, this is really the crux of why understanding this condition is important for what we do day to day. So the consequences of TBI have impacts on people and their relationship to the jail or prison environment. And many of these are time limited. So we'll talk in a little bit about the incidence of TBI, but the fact is that many people sustain TBI while they're incarcerated, and their symptoms are going to play out in the jail or prison environment. And for many people, we feel that TBI may be the beginning of a feedback loop where the TBI may be sustained because they're not doing well in jail or in prison, and then they can start to do worse. So I think that some of the education for correctional staff and medical staff in incarcerated settings is really geared towards an understanding of this potential cycle and an awareness that can allow us to respond in ways that might not perpetuate that cycle. So I'll just go through a few of these. Attention deficits are very common after TBI, and these can lead to difficulty focusing on required tasks or directions. This is also highly prevalent among adolescents, and we know that adolescents can struggle in the jail environment as well. Memory deficits make it difficult to remember rules or directions that were given to you by a corrections officer. Irritability or anger can lead to incidents. Slowed verbal responses and physical responses can be perceived as uncooperativeness or disrespect. This one in particular to me resonates for the jail environment, where the response and the prompt response to different stimuli is perceived as a communication in our setting. And I think for our corrections officers to know that when a person doesn't respond right away, or when a person responds slowly, or doesn't understand an obvious command, that might be something different than disrespect is crucial to preventing these cycles of repeated injury. And then, of course, uninhibited or impulsive behavior, which is a comorbid problem in our population to begin with, can be worsened, leading to problems controlling anger and sexual behaviors that can lead to further altercation and further injury. So, screening. There are many screening instruments available for TBI. They range in the time that it requires to administer them. I'm going to talk a little bit about how we establish prevalence in our population using a screening apparatus called the TBI Q, which takes about 15 minutes to administer. It has the advantage of being validated in correctional populations, but it can take even longer than 15 minutes, especially if the person being interviewed has multiple TBI in the past, as many of our patients do. There are quicker screens, as Ashley mentioned. The OSU TBI ID is about 5 minutes, and the Health TBI is about 5 minutes. These might make sense for different correctional settings to incorporate into their intake screening, but I think it depends on the volume of those intake screenings. Here in New York City, we have about 70,000 admissions a year, and we do a full history and physical on each of those. So that visit is precious to us, and anything we add to that visit has to have a very clear usefulness, and we have to be clear with ourselves and our staff about how that's going to impact our patients' care going forward. And this was a crucial reason that we have not yet integrated TBI screening into our intakes, because it's unclear how a positive for any one individual in our system should inform their care, given this very high prevalence across the board. Now that is for historical TBI, and I'd like to distinguish that from incident TBI, or TBI that occurs in our setting, TBI that happens while our patients are with us. So basically our strategy was to screen a small sample of adolescents coming into the jail, just to establish for ourselves, as it's established in the literature, that the prevalence of TBI is very high in this population. And then to think about what kind of interventions can we do on a population level. So what kind of interventions can we give to a whole housing area? Some of the people who might participate might have TBI, others might not. Others might have family or friends who experience TBI. And as I mentioned, we decided against the implementation of the system-wide intake screening. So we decided instead to assess prevalence and incidence. And I'll go through quickly the results. So the prevalence was determined using this TBI-Q. And the incidence was determined using our electronic medical record. So we applied the TBI-Q to adolescents. In particular, we focused on adolescents because this is a problem that in the literature is more prevalent, or has a higher incidence among adolescents. But adolescents have had a fewer number of years at risk when compared to older incarcerated adults. So we wanted to establish that even in adolescents who might be quite young, that the prevalence in our population was high. Before I quoted 60% as the prevalence for incarcerated populations generally speaking, and indeed we found that the prevalence in adolescents in our setting was about 50%. So we applied the TBI-Q to 384 new admissions to our adolescent facilities. 300 males and 84 females. They had a median age of 17.2 years. So this is on the younger end of the spectrum for our patient population. And we were able to find some correlates between those patients who reported a TBI, and we define that as one or greater injury with altered mental status. And we did find in our system, as one would expect, that there was a higher prevalence of M status for those who screened positive. M status in our setting is a marker for interaction with mental health staff. So it's a marker for mental illness and for increasing numbers of mental illness diagnoses. We also saw that those who reported TBI had higher rates of injuries, that more of their injuries were related to assault, and that they had a statistically significantly higher ratings on symptom scales. So there's a symptom severity scale and a symptom frequency scale that asks the patients about symptoms that are known to be downstream consequences of TBI. So it's a marker that suggests that those TBIs that we were picking up on the screening were in fact having real clinical effects on the patients who sustain them. As I mentioned, the prevalence was about 50%. We also looked to see if there was any impact on recidivism, and we didn't see a relationship there. For our adolescent population, the recidivism rate was quite high, ranging from 56 to 72%, but we didn't establish a relationship with TBI history and recidivism. I'm going to talk a little bit about incidents. So the slide on the screen is a picture of our electronic medical record. implemented in all of our 12 jails in the New York City system. And it allows us to look at our population from a public health standpoint and to have continuity of care as patients move in and out of the different jails in our system. One of the crucial breakthroughs that we've been able to implement with our electronic medical record is to do surveillance for different conditions that are important to correctional populations. And probably the biggest public health risk and public health problem that we see in our population is injury. The box in the middle of the screen is a template. So this is something that our doctors, our wonderful doctors, TAs, and nurse practitioners who see patients in our system merge into the electronic medical record every time they see an injury visit. And it gives us reporting information that can allow us to monitor injuries across the system over time and to identify the characteristics of injuries that are sustained in our system. Because we were interested in the incidence of TBI, we also added 3 questions to our electronic medical record injury template. We try to keep these things simple so that our providers can do them and still take care of their patients, which is their primary task. But we also feel that the data that is produced by these templates is very important. So my box got a little off-center, but it's really the 3 questions at the bottom that we added as a marker for mild traumatic brain injury. So we ask every injury now, did the patient have a blow to the head? Did the patient ever lose consciousness? Was the patient ever dazed and confused after the injury? And these questions, the blow to the head question, affirmative, plus either of the other 2 affirmative, meets the criteria for the American College of Rehab Medicine definition of mild traumatic brain injury, or what traditionally would have been called concussion. It doesn't allow us really to distinguish who had a very severe brain injury versus who had a more mild one, but it is a marker for sort of a very sensitive marker for mild traumatic brain injury that occurs in all settings. So we looked at the data generated from this injury template over about 16 months in our jail system, and we found that during that time we had about over 24,000 injury visits. About 28,000 of those were in adults, and about 4,000 were in adolescents. The rate of head injuries for the injuries as a whole was about 12.7%. So of those 24,000 injuries, about 12.7% had a head injury or a blow to the head. And the rate of TBI in those injuries was about 2.3%. So during those 16 months, we had 583 new mild traumatic brain injuries sustained in our system. An interesting relationship, this phenomenon is known to be more common among adolescents, and this has to do with behavioral disinhibition and all the things about adolescence that make us predisposed to violence, to having problems, to having head injury. We did find that the rate of head injury was higher among adolescents in our system than it was in adults. But what we found to be very interesting was that the actual rate of TBI was not different. And what that possibly suggests to us is that adults are having a very high rate of traumatic brain injury in our setting. It's not a problem that's just limited to adolescents, as it's often thought of in the community. And B, it's possible that something about the adults predisposes them to having a traumatic brain injury when they get hit in the head. In other words, that the adolescents get hit in the head more, but it doesn't convert to the symptoms of a traumatic brain injury with the same frequency as it does in the adults. So we compared this incidence to incidence that's been established in the community. One caveat about this data is that it's very difficult to compare data that's gathered in these very different ways. So generally when traumatic brain injury is studied in the community, epidemiologists look at hospital records to see who arrived at the hospital and was treated for traumatic brain injury. That's the way that this incidence is generally established. We know that that misses a large number of traumatic brain injuries because many traumatic brain injuries, especially mild cases, don't present to medical care. So it's been difficult in the community to establish a true prevalence of TBI. So these are a few studies that have looked at the incidence of TBI in the community. Sports-related injuries, which you hear a lot about, actually, I was surprised, had a fairly low prevalence, incidence, only 31 per 100,000 person years. There was a review paper in 2004 that looked at a lot of different studies on the incidence of TBI in the community and estimated between 100 and 300 per 100,000 person years, though they also acknowledged that many of the cases were not picked up, and they estimated that the true prevalence in the community may be greater than 600 TBI per 100,000 person years. And that would be accounting for cases that don't seek hospital care. Most recently, there was a study in New Zealand which cast the widest net to find TBI using hospital and primary care records, and they found an incidence of 790 per 100,000 person years. So you can see that the incidence is almost rising as time progresses, as our patients and the medical community becomes more aware of the phenomenon of TBI. You see the diagnosis and incidence starting to go up. That said, the incidence that we found in our jail system was higher than any of those settings. And the rate of traumatic brain injury among adolescents in our jail was over 3,000 per 100,000 person years. Again, this is measured with active surveillance. Our electronic medical record with that injury template is a more sensitive way of picking out mild traumatic brain injury than anything that exists in the community. But what it does show us is that this is a real problem in our setting and that it's a common occurrence in jails, which fits with our experience of the jail environment. It's also important to point out that about 51% of our mild traumatic brain injury cases ended up seeing an ED doctor, an emergency department doctor, which may be a marker that they would have gone to the ER in the community as well, though that may not be a safe assumption. But even if we had only half the rate of TBI that we found, that would still be a higher rate than has ever been described in the community. So what can we do in corrections? This is a question that we struggle with. I think one of the things that we want to work towards but have not yet implemented is to think about what we can do for a patient immediately after they sustain a traumatic brain injury in jail. So one of the clearest recommendations for how to handle an acute event, especially a mild event, is to provide the patient a time period of physical and cognitive rest. So just taking a break. And for adolescents in school, this might mean a decreased workload in class. For adolescents in sports, it means, sitting out on the sidelines for a period of time until you're sure that the symptoms are gone. For adolescents in jail, it's not clear how we operationalize this. Jail is not set up to really provide physical or cognitive rest. And we struggle to think about how to pull a patient out of what might be a dangerous situation in that acute phase after they've sustained a traumatic brain injury. Oftentimes we can use our infirmary, and that's an important resource where we can kind of take people out of the jail that they were in, move them to a place with a much older population, sicker population where things are sort of quieter and safer. But this can be problematic because those patients themselves may be experiencing the after effects of traumatic brain injury, and they may be having emotional dysregulation. They may be prone to violence and having difficulty navigating the jail environment, which could put our other patients in the infirmary at risk. So this is a question that we haven't quite answered. What to do in the immediate after TBI period with regard to the jail environment? How can we sort of create a separate space for people to voluntarily remove themselves from the high-paced, high-risk, high-decision-making dormitory environment? The other thing that we can do is educate our staff. So correctional staff, as we mentioned, the more that they have an awareness of the behavior patterns that can follow TBI, the more understanding they're going to be. And I think that this is a key tool in identifying patients and situations that need to be de-escalated versus patients and situations where someone is actively trying to create a problem. Similarly, our medical and mental health staff have a lot to learn about TBI. Understanding epilepsy and mental illness in the context of TBI is crucial towards treating the symptoms that might come after TBI, and also having that expectancy about the natural history of the disease. So when somebody has a worsening of their attention problem, for example, in the acute aftermath of a TBI, it would be better if we could potentially not diagnose them with a disease like ADHD. If we know that this occurred and we can give it some time to improve on its own, it may not be so much an organic mental illness as it is a consequence of their injury. The other thing that we've embarked on is thinking about group treatment. So a lot of the strategies to treat TBI in terms of the behavioral dysregulation involve cognitive behavioral therapy and basically interventions for anger management, behavioral control that we feel would benefit even our population who has not clearly sustained a TBI. So a housing area-based intervention to help people have skills to control their emotions, to take a step back and to de-escalate situations could be a treatment for TBI at the same time that it's valuable to the smaller population who has not sustained a TBI in the past. Screening, as I mentioned, is something that we are constantly considering but have not yet implemented because we don't know exactly how we would respond to somebody who screens positive versus somebody who doesn't. And then I wanted to mention briefly the complexity of conferring a special status to somebody who has received a traumatic brain injury. Those of us who work in correctional health know that to have a status can be very problematic. And there is really very little objective corroboration. Ashley mentioned observing a patient in various settings in the jail, and that's important. But in the end, our diagnosis of TBI depends on the patient giving us a history. And to confer a special status, a special housing arrangement, or treat people differently because of TBI would be very complicated in our setting if it was perceived to confer advantages in the jail setting and led to secondary gain towards achieving that status. So that's one of the things that we're very cognizant of when we don't really focus on the individual level so much as we focus on the population level when we think about treating TBI. And then the last point is legal involvement. So we here do a fair amount of work that would be in the bucket of compassionate release. And the question is, if this relationship really holds true that behavior can be influenced by traumatic brain injury, what are the implications for the legal system? And what role do we as correctional health professionals have to play in advocating for individual patients who may have had a credible history of TBI that led to a credible change in their behavior patterns that may have led to subsequent offending behavior? This is a really complicated question, and it's something that we're just beginning to think about and that we have not, up to this point, really involved ourselves in. And I'm going to turn it back to Ashley.
All right. So, Dr. McDonald and I spent a lot of time talking about overall, what is the message here? And I think it's, we have a lot to learn. Raising some awareness about the issue, I think, is so important because, we've been checking the mental illness and substance abuse box for a long time, and I think, moving forward in the homeless community and the domestic violence community and substance abuse treatment and the correctional health and probation and related fields, I think even more and more are going to have to take into account this brain injury business. And so there's no good answer in terms of management or strategies, but I think we're starting to pay more attention to it, and we're getting more information about it. And so just quickly, I wanted to just kind of share. So these are rowboat tip cards, and these were developed as part of the Maricopa County Justice and Mental Health Collaboration Project with the Arizona Center for Applied Behavioral Health Policy. I did a training for Maricopa County Sheriff's Office, and this was sort of developed as something that correctional health services and detention officers could sort of have just sort of on hand. And it's just got some facts about the cognitively impaired, because I felt it was important to differentiate cognitively impaired from traumatic brain injury, because at the end of the day, although we're talking about traumatic brain injury, it doesn't really matter why somebody is cognitively impaired or having difficulty following the rules. It only matters that it's happening, and we need to figure out a way to manage this individual better and help them navigate out of the system or be successful in the system that they're in, no matter what. So on the other side of the card, there are just some strategies with the rowboat acronym. I love acronyms. That are just some very common sense, simple suggestions about how to give information, how to make sure the individual is understanding the information, and then just common symptoms and that sort of thing. So in my experience in terms of case management, and those of you folks who are in the community, the thing that works the best for the folks that I work with is repetition, and errorless learning repetition. So giving them information, making sure that they're learning it the right way every time. Giving things in step-by-step formats. I literally write down, step 1, get on the bus. Step 2, get off the bus. Step 3, turn right to the corner of First Avenue and Central, or whatever it is. Maps, I've had a lot of individuals say, oh yeah, I totally know where that is, and they have no idea. So getting maps out and kind of past findings for them. Writing scripts is something that I do a lot. And so when somebody is going down to our local TBS to apply for food stamps and access, which is our state's Medicaid, if they have difficulty communicating or they have difficulty remembering why they're there, they can hand them the piece of paper that I gave them that has exactly why they're there and what they need, and that can help the person behind the desk kind of get things started for them. So just really a simple strategies like that to help kind of make sure that things go in the direction that you're hoping them to. So this next slide, and I'm just going to talk for a minute about this, just in terms of things that I found that are out there that are just incredibly progressive in terms of looking at how to address this problem. And I think the more of these kinds of projects, and the more interest people have in obtaining funding to run programming to really look at this brain injury situation, I think the better off we're going to be in coming years. So the Minnesota project was awarded a HRSA grant in 2006. And so there were sort of 3 elements of this project. The first one was screening and identifying, which Ross kind of talked about the different types of screenings that can be utilized. And I think they partnered with the Minnesota Brain Injury Association, and so they did the screening and identification, and they did initial screenings of 998 male inmates from 2006 to 2007. And so 82 of them were persistent with findings from the studies done in New Zealand that Ross or Dr. McDonald was mentioning. So it was, and then 96% of female inmates, 100 female inmates also reported, and then 57% let's see, a screening of 50 juvenile, 98%. So again, those really high statistics in terms of correlation. So they did the screening and identification, and then they developed some education modules for all of their staff. It was a 3-module program that each staff member had to go through. And then lastly, looking at the community reentry process for individuals with traumatic brain injury, because there are some hard and fast resources out there for people that have a traumatic brain injury. For example, in the state of Arizona, we have a specific vocational rehabilitation program that takes care of people with traumatic brain injury. That really understand the condition and can help people access resources for brain injury rehabilitation that would be a huge benefit to somebody that's recently been separated and is looking for the next thing. So just a quick example of projects and things that are going to need to happen coming to a theater near you to make sure that we're addressing this problem and we're learning as much as we can about it, as quickly as we can about it. So with that, I'm going to turn it back over to Nicole.
Great. Thank you so much, Ms. Birdwell and Dr. McDonald. That was a wonderful presentation. Lots of information that was covered. We only have a few minutes left, and we have a bunch of questions that have come in. I wanted to first question, and we had a number of questions around this. What would you recommend in terms of a treatment approach for someone who has a TBI along with a co-occurring mental health or substance use disorder?
Well, I mean, Dr. McDonald, I'm going to take a stab at this and then feel free to add. Getting back to the ideal, I mean, if we're talking perfect world, it's, the interdisciplinary brain injury rehabilitation program that's PARF accredited, it's PT-OT speech, it's neuropsychology, and then, obviously, if there's a comorbidity with mental health issues, we want to involve, a psychiatrist that is skilled in working with the neurological population, and we're so fortunate to have a neuropsychiatrist here at Barrow and St. Joe's, and she's intimately involved in the rehabilitation programming from a talk therapy perspective, as well as looking at sort of the correct medication cocktail to keep somebody in a place where they can really benefit from the rehabilitation program. Because if those mental health issues are really prominent, it's very difficult to rehabilitate somebody until those issues are stabilized.
Okay, great, thank you. And as a somewhat related question, a lot of questions came in for people who have clients on community supervision, and this question has to do with, relative resources. We're coming from a small community. Any suggestions on how to get a client evaluated and treated in the community?
So again, Dr. McDonald, please feel free to jump in any time here. So if you're in a small community, unfortunately, you pick your resources by where you choose to live a lot of times. And so if you're in an area where there is not, really, a neurological care center, then you're going to have to find a major city close by, or the nearest one close by. And then in terms of assessment, making an appointment with a neurologist and talking with them about the history of the injuries to your brain, hypothetically, and again, every physician is going to be different, but my guess is that, if you're talking a lot about having, repeated assaults to your brain or head injury, that the likelihood is that they will probably order some imaging and take a look to see if there's been any structural changes to the brain. And then to follow that, I would say the next best thing is neuropsychological testing, which will really help to determine that individual's level of cognitive function, which can help in one of two ways. It can either help in terms of looking for, vocational possibilities in terms of vocational rehabilitation, or on the other side of things, assisting somebody with a Social Security application is a lot easier when you have medical documentation of that person's level of ability from a cognitive perspective.
But I would just say that it's challenging even in New York City. So we don't really, our patients don't have ready access to an integrated rehabilitation setting like where Ashley works. And, you know, for the severe cases, we really struggle with where are these patients going to go. And we know that for many of them, jail is probably not a good place. You know, they don't do well in the jail setting. But I think that the community resources are, even in big cities, are generally not there yet. And I think, you know, as there's more and more attention to this phenomenon, I hope that the legal system also will have a better understanding, and that there will be more long-term facilities that might be open as alternatives to incarceration for some of the patients who come to us who probably shouldn't be in the community, but also probably should not be in jail.
Well, and I think, too, just as a side note in terms of resources, you know, I think almost every state has a brain injury association or you know, some variation of that. I know in the state of Arizona we have the Brain Injury Alliance of Arizona that has an information and referral line that you can call and get information about what resources are available and that sort of thing. So if you have somebody you're working with and you're not quite sure where to start, or, you know, if there are providers in your area or around your area, I would say that probably the best place to start is, you know, just get online and look for a brain injury association or a brain injury alliance or a brain injury something in your state and call their information and referral line. I'm sure that there are those kinds of resources as well. I know I use ours on a weekly basis, as people know me by first name over there. So,
well, thank you. You know, this concludes our webinar. We don't have any more time for any more questions, but I did want to send a big thank you to Ashley Bridwell as well as Dr. Ross McDonald. Thank you all for your attendance and participation. Also like to extend thanks to the Bureau of Justice Assistance for sponsoring this event. A recording of this presentation will be available online early next week on our website. The website is on your screen there. And finally, when you leave this event, a brief survey on this webinar will pop up on your screen. We would very much appreciate your feedback. In addition, there's a sign-up for monthly mental health and reentry newsletters. We encourage everyone to sign up for these to learn more about future events, current research trends, and other resources in the field. Thank you again for your participation today, and we look forward to having you on another webinar soon.